Okay, well, welcome everybody. It's wonderful to have so many friends back on for rounds today, and we are really excited. We have Dr. Heidi Syme presenting a discussion on an article that evaluates the use of telmisartan versus benazepril for the management of proteinuria. And Hattie, thanks so much for volunteering to present, and really, really appreciate it. And I'll certainly make the plug out for anybody who would like to present. We are certainly having some open slots that are still available, and we're happy for anyone who would be interested in leading the discussion. So with that, Hattie, I'll turn it over to you.
Thanks, JD. And I mean, I can't actually see, but we've got some people with us, have we? There are some people online already.
We have 38 people at the moment, and more are logging in by the minute.
Excellent. Well, that scared me now. I thought I should put a picture of myself up there for those of you that don't know me, but that was a bit painful, so I've put an avatar instead. Although I do now look a little bit closer to this image, having managed to have a haircut this week for the first time in 6 months.
Hey, Hattie, could you do one favor for us too? If you just don't mind clicking the hide button on your screen, that'll take away the banner and it won't. Yeah, perfect. Now we can see your full slide. Thank you so much.
Okay. So I mean, this is a plug along the lines of what JD was saying. I mean, I have to say that last night, when I hadn't made any slides for today's presentation, I was really thinking about bailing, and I think the problem we've had up to date is almost that people have done such a good job that the bar has been set really, really high, and perhaps that's inhibiting people from presenting these sessions. And so what I decided I would do is to fall upon my sword and to try and redress that balance, I'm afraid. On the spectrum of I'm trying to aim to do something. So I've been through the paper and I've pulled out images from it and illustrated the results and some points that I think we can talk about together. But I certainly haven't done the extensive literature search that other people have done, and I haven't inserted questions. So I'm just going to be asking you for input as we go along. And I would really encourage people, because it's always interesting to see what other people have to say about papers. So I would encourage other people to do the same and just, agree to do a session and to pick a paper, and so that we can all have a discussion about it. So that said, the paper that I wanted to talk about is this one from the group at Georgia. It's a paper that I really, really like. Although I did like it slightly less at 3 o'clock in the morning this morning when I realized it was 20 pages long and just how much stuff was included in it. And at that point I was starting to go off it a little bit. But fundamentally, I think this is a great study, and real kudos to them, because whatever way you look at it, it must have been a huge amount of work to put this all together. And something else that I thought that was good was that often we have things where you can see that actually it was a single study, but it's been pulled apart into 2 or 3 minimal publishable units rather than being published as a whole. And I really appreciated the fact that it was published in its entirety. So to start with, just a very brief encapsulation of what the study was about. So the sorts of things that you write down if you're studying for boards, when you're sort of summarizing the abstract and going, okay, what does this paper tell me? This was a randomized clinical trial in which they compared telmisartan with enalapril, and they used it to treat dogs with renal proteinuria. So the inclusion criteria was that the UPC had to be greater than 0.5 if they were azotemic, or if they were IRIS stage 2 and above, or if they were non-azotemic, then they had to have a UPC of greater than 1. And then they potentially, if the UPC came down to less than 0.5, then the dogs were just rechecked at day 120, but otherwise they went through monthly dose escalations of each of the drugs individually, and then if the UPC remained greater than 0.5, then they used the drugs in combination. And in terms of the take-homes, they saw in general a greater reduction in proteinuria with telmisartan, and although it was relatively small numbers of dogs that received the combination of drugs, when they were used in combination, then about a third of the dogs developed worsening azotemia, so an increase in creatinine of more than 30% from baseline. So if we start by looking at the introduction, for a paper that was nearly 20 pages long, the introduction was actually only about half a page, really quite short and sweet. And the main points that they made in it were that proteinuria is a negative prognostic indicator in dogs and in other species, and that antiproteinuric therapies are considered to be beneficial and the standard of clinical care. And treatment in many of the studies that have been done so far have used ACE inhibitors for this treatment, but usually at a standard and relatively low, sometimes once daily dose, and there's been no attempt to optimize that treatment and no dose escalation of that. And then they go on to talk about the potential advantages of angiotensin receptor blockers over use of ACE inhibitors. So I'm sure everybody that's on this call is very familiar with these, and I'm telling you stuff that you all know already, but just to reiterate the point in terms of treatment with ACE inhibitors. So in terms of the renin-angiotensin cascade, you've got renin, which cleaves angiotensinogen from the liver to form angiotensin 1, and then that's converted by the ACE enzyme to angiotensin 2, and then this binds to its receptors. And most of the classical effects of RAS stimulation are thought to be mediated through the AT1 receptor. So this is what causes the vasoconstriction, the sodium retention, the stimulation of aldosterone, and so on. But there is also the AT2 receptor, which in general has weaker and generally the opposite type of effects. And this is probably less important in normal physiology, but may become more important in pathophysiological states. And so if we treat the patient with an ACE inhibitor, then we have a reduction in angiotensin 2, and we have less binding to both of these receptors. But in contrast, if we treat the patient with an angiotensin receptor blocker, which binds to the AT1 receptor, then the angiotensin 2 that's produced, and more of this may be produced if you've had an antihypertensive effect and that stimulates production of renin and stimulation of the whole system, then the angiotensin 2 can bind to the angiotensin 2 receptor and cause vasodilation and other potentially beneficial effects. And then the other theoretical advantage of treatment with an ARB would be that if you have escape from the blockade that you've caused with your ACE inhibitor, because there are other proteolytic pathways by which angiotensin 1 can be converted to angiotensin 2, then this escape phenomenon would make the ACE inhibitors less effective, but wouldn't prevent the actions of your ARB. So the only thing that I guess I thought in the introduction, I wasn't sure whether it would have been a useful inclusion that wasn't there, was that when they discussed the antiproteinuric therapies being the standard of care, I mean, it's true, and they have been proven to be beneficial in terms of treatment of glomerulonephritis and in the dogs with the Alport type syndrome, where they've got the defect in the type 4 collagen in the glomerular basement membrane. But if you take dogs with what I call common or garden CKD as a whole, then actually treating with antiproteinuric therapies aren't necessarily beneficial. And this is just one paper where they looked at benazepril in treatment of dogs with chronic kidney disease, and you could see a trend perhaps towards more positive effects when you looked at the more proteinuric, less azotemic group, but overall it wasn't beneficial. Now that might have been because it was an ACE inhibitor, not an ARB, but yeah, that was just something that wasn't really addressed, but perhaps because the paper's focus was on proteinuric patients, and obviously not all patients with CKD are going to be proteinuric. So that was my thoughts about the background and the introduction. Did anybody have things that they wanted to add to that before we move on to the methods and results? Silence. Nothing in the chat, JD. Okay, so then in the methods, so I thought this was really elegantly designed, this study. So it was prospective, randomized, all done at the University of Georgia, double-mask clinical trial. They excluded patients with, well, they listed a long list of conditions, but I've just sort of lumped them into sort of non-renal causes proteinuria, so urinary tract infections and stones and other things that might potentially cause proteinuria, or diseases that might be reversible, things like heartworm disease and things, and patients that were already hypertensive or hyperkalemic. And then they randomized them on the basis of whether they were hypertensive or not and whether they were azotemic or not. So they had essentially 4 treatment groups with block randomization, then in groups of 4, and with a 1-to-1 ratio of patients treated with enalapril and talmosartan. And then the talmosartan was given, the initial dose was 1 mg per kg given in the morning, but they also got a placebo in the evening, and then enalapril was given at 0.5 mg per kg twice daily. And by adjusting the concentration of these drugs, they were able to ensure that the volumes of the 2 drugs were equal, which helped in the blinding process, which I just thought was neat. I mean, it's not rocket science, but it was an elegant way to do it, I thought. And then the dogs could have amlodipine alongside, so there were, I think there was just 1 or a very small number of dogs that were already on amlodipine at the start of the study. And but if they weren't on amlodipine and they were hypertensive, they could be started on that alongside. And that was a relatively conservative doses, which was probably appropriate because it was being used in combination with these other drugs. So starting at 0.1 mg per kg per day and increasing up to 0.3 mg per kg twice a day. And they were also, the majority of them were receiving a renal diet, which they needed to have been on for at least 2 weeks before the study started. And then in terms of the study, they all at baseline had their blood pressure measured, had renal biochemistry, urinalysis, and UPC, and they tried to get 2 baseline UPC measurements, so taking one from the preceding 2 weeks and then one at enrollment. They had urine cultures, abdominal ultrasound, and either a heartworm test or a 4DX test. And then phase 1, they had 30 days of treatment at the initial dose of the drugs. And then in terms of the dogs that had UPCs that decreased to less than 0.5 were then seen again at day 120. But if their UPC hadn't reduced to less than 0.5, they had a dose escalation and subsequent dose escalation at monthly intervals. So the doses went, if they were on talmosartan, from 1, 2, and 3 mg per kg, and if they were on enalapril, half that dose. And then the final phase was to combine their highest dose with the starting dose of the alternate drug. And then at each point, if the dogs became had a UPC less than 0.5, they were then followed up at day 120, but excluded from further analysis. And at all the rechecks, they had their biochem and their blood pressure, and also after any dose escalations, 7 days after the dose escalations, and then they had urinalysis and UPC at each 1 month after the doses were changed. And the UPC measurements at this point were based on 3 aliquots, and the blood pressure measurements were made by Doppler. And so this is the same thing sort of outlined in a diagram in the paper. In terms of the statistics, they did a power calculation, and they had an interim analysis that was done by an independent statistician to verify that they could complete the study. And they had a lot of fairly standard statistics, so t-tests, rank sum tests, Fisher's exact tests, and then with the Kaplan-Meier they had a long rank test. And they also had something which I meant to look up, but I ran out of time, and which is a stratified non-parametric permutation test. And although I don't know the details of how it was performed, I believe I understand why it was performed, in basically to look at the patients, to standardize them in terms of their level of starting proteinuria, because patients that are more proteinuric, you potentially are going to see a greater reduction in UPC with treatment. So this allows some sort of correction for that effect, or some sort of standardization to make sure that what you're seeing is not just an effect of inequality in terms of your baseline data in the 2 groups. I I think. And they did analysis by intention to treat. Does anybody want to chip in, or shall I go to the results? Okay, well, so in terms of the results, they had 48 dogs that were screened and 39 of those enrolled. Quite a few of the ones that weren't enrolled were Cushingoid, and they could be enrolled if they were Cushingoid, provided they were stable on treatment. Although I looked at that and I thought, well, I'm not sure if I would have done that. But then when you actually looked at the data of the drugs that the dogs were receiving, it looked as though there was only one Cushingoid dog that was actually included in the study. They had 74% of the dogs were non-azotemic at enrollment. And one thing that I wasn't exactly clear on from reading the paper, and I sort of wondered, was how those dogs were identified, because there's no discussion of sort of the dogs having clinical signs. I mean, some of them had pre-existing conditions and things like that, but nothing that you would immediately say would bring them into the veterinary surgery to be evaluated. I mean, some of them were quite proteinuric and might have been hypoalbuminemic and stuff as a result, but many of them weren't. So whether it was just healthy dog screening that allowed them to be identified, or whether the dogs were sort of subtly unwell in some manner, given that they were non-azotemic, I just wasn't quite sure why these patients came to veterinary attention, so to speak. The two groups of dogs with the two drugs were very well matched. Numerically, the UPC median was just slightly higher in the UPC group than the enalapril group, but when you look at the range of values that were included in each group, they were pretty similar. And they had just 25 of the dogs that completed the study, with 5 dogs removed from each group, so 10 overall, due to increases in creatinine, potassium, or in one dog's case, I think both. And in 3 cases, they were removed due to clinical illness, including one dog having Borrelia. And there's a nice consort diagram in the paper, which I'm sure the words are much too small on this for you to be able to see it, but it does outline very nicely at which point dogs were removed as the study progressed. And then in terms of their results, so if we look at the changes at day 30, so one of the big findings, if you like, from this study was that there was a greater reduction in UPC in the dogs that were treated with telmisartan than those that were treated with the enalapril, although the enalapril was effective as well. And then the data on the right here shows the actual UPC measurements from each individual dog, plotted over the different time points. But obviously, if the dog showed a very good response and the UPC level went down to a low level, then days 60 and days 90 weren't performed, because the dogs just came back in at day 120. And the black bars represent the telmisartan treated dogs, and the dotted grey bars, those dogs that were treated with enalapril. And And the data is also outlined in two tables, which I've sort of cut and pasted and put together so that you can compare them. So at the face of it, these tables look initially very, very similar, but the difference between them, so table 4 is looking at patients that have a greater than 50% reduction in UPC from their baseline, and then table 5 is looking at whether the UPC came down below 0.5. And what was shown was that there was a difference in terms of the percentage reduction in UPC. So there was more telmisartan treated dogs had a reduction of 50%. So like 80% of the dogs treated for the first 30 days at the 1 mg per kg dose had that level of reduction, compared to only 35% of the dogs treated with a 0.5 mg per kg BID of enalapril. And then with the subsequent dose increases, numerically, it still seemed to favour the telmisartan treated group, but obviously there were decreased numbers included in this, because some of the dogs were excluded from day 60 and day 90 because they'd already achieved a UPC of less than 0.5. And then at day 120, actually the comparison there is again not significant, but because you've got the combination of the two drugs and relatively small number of patients being treated, and because actually overall in the combination of the drugs, most of the dogs were successfully treated in terms of reducing their UPC. And then when you look at whether their UPC came down less than 0.5, then actually there was no difference between the groups at any time point, although looking at the data you do still get the feeling that it, if anything, favours the telmisartan group. So it was relatively uncommon, or not that many of them had the UPC come down below 0.5, at least at the starting dose. And then they also have some box plots which show the actual changes in UPC that are seen at each time point. And what becomes a little bit difficult to keep track of is just because the numbers of animals and the groups of animals that are included are obviously slightly different on the different days, with the data from days 60 and 90 tending to reflect perhaps the dogs that were less responsive to treatment, arguably, in that they didn't have their UPC come down less than 0.5, but they also may have been the dogs that were less proteinuric to start off with, so they were more likely to meet that threshold and then get excluded from these follow-up points. And then the final graph on the right is the maximum tolerated dose that the patients receive. So in all cases, they seem to favour telmisartan treatment. And then in terms of the combination of drugs, obviously this is small numbers of patients, because to reach this point, the patients needed to have not been excluded because of increasing creatinine or development of hyperkalemia or concurrent disease. So they needed to have made it through to this point and still have a UPC of greater than 0.5 in spite of quite a high dose of the individual drugs. And then when they received the drugs in combination, so with the addition of the second drug, there was a further reduction in UPC seen, but a third of these dogs did develop an increase in creatinine, a more than 30% increase in creatinine. And then this looks at the percentage changes in UPCs, looking at the patients that were just treated with the drugs on their own, and then looking at the reductions with the dogs receiving the drugs in combination, although you've got to remember that this is only 3 dogs, so it's relatively limited sample size. So other things that I took out of this. So in tables 6 and 7, when you look at the blood pressure in the 2 treated groups, in general, the reduction in blood pressure was greater with telmisartan, although not at all time points. So, for example, if you looked at day 30, which was the initial follow-up time point, then the blood pressure reduction was about 12 millimeters of mercury with the telmisartan versus only about 1 with the enalapril. There wasn't any difference in the delta creatinine or delta potassium between the groups, but the change in creatinine was substantial in both groups of combinations of drugs. So whether the dogs got enalapril first or whether they got telmisartan first when the drugs were used in combination, there was quite a marked increase in creatinine, or marked, I guess it depends where they were starting off from. If their creatinine was very low to begin with, it may still have been inconsequential, but there was a notable change, although this wasn't different between the 2 groups, but limited sample size. And when they looked at hematocrit, again, not at all time points, but there was a slightly greater decrease in hematocrit in the telmisartan group, sort of up to 10% at some of the time points, which you could argue might be clinically relevant. So although I loved this paper, I think I was running out of steam by the time I got to figure 9, and this is looking at the data in terms of a Kaplan-Meier analysis and comparing the groups by log rank test. And I guess some of this is stylistic. I'm not sure what additional information this brought to me. I think it was great data, and I think it's really interesting to look at, but I'm not sure whether this brought more to the party, so to speak. And also tables 2, 3, and 8, where there were lots of, like, all the drugs and the concurrent diseases and things that the patients had. I sort of ended up wondering when I was reading it whether the authors that had included it to be really thorough and to make sure that everything was meticulously determined. It was great that they'd done that on the one hand, but then I was like, I'm not sure whether I really wanted to know it with this level of granularity. But then I also wondered if actually it was the reviewers that had made them put it in. So I ended up being curious about that. sort of I wanted to know that they'd done it, but I'd quite like it to have been an appendix so that I can just refer to it if I wanted to, if you see what I mean. So that was what I took from the results. And in terms of the discussion, again, I thought this was relatively brief considering the amount of data and the amount of hard work that had gone into the study. They reached that telmisartan caused greater reduction in UPC than enalapril, either at the initial doses and with escalation. And in terms of referring back to the previous literature, they pointed out that this fits in with the in vitro study where they've given experimental dogs, they've treated them with exogenous angiotensin II and monitored their blood pressure and been able to show that telmisartan is more effective than other drugs that are more effective than ACE inhibitors at blocking the response to that drug or the response to the angiotensin II, and suggesting that the reason that telmisartan outperformed enalapril was because of better RAS blockade, and I think that's potentially true, and it's definitely one explanation, and perhaps the most likely explanation. I think there are other things that we could think about, and I'll talk some more about those in just a moment. They also talk about it showing greater antihypertensive efficacy, and then they brought in something that I wasn't aware of in terms of which might fit in with the fact that the hematocrit tended to decrease in the angiotensin II regulates the renal transcription of erythropoietin. And then they also mentioned the limitations, and actually I didn't think I didn't have big issues with any of the limitations that they were pointing out. And again, you never know with limitations whether they were the author's limitations or the limitations that the reviewers made them put in. But the limitations that they mentioned were the lack of biopsies of the kidneys of the dogs that were included, the missing data, so the fact that the dogs didn't necessarily have samples collected at day 60 and day 90, and then the fact that the enalapril was compounded, which again I didn't have a particular issue with. But my additional speculation, the things that I thought when reading this paper is, it's so the effects, the superiority apparently of telmisartan, clearly that could be because of the reasons that were outlined in the introduction to do with either escape and stimulation or production of angiotensin II and potentially aldosterone as a consequence of that, or through the binding to the AT2 receptor. But there are possibly other mechanisms that might also be at play. One thing that I think is interesting is the fact that the telmisartan seems to have great antihypertensive efficacy, and so do these things go hand in hand? And is the reduction in proteinuria, is it only due to the hemodynamic effects, or could there be other mechanisms as well? And there are other mechanisms of action that have been described for telmisartan, and without going into any detail, just sort of looking on PubMed, there are legions of them, but and these aren't necessarily common to all the drugs in the class. So in at least for some of these, they seem to be peculiar to telmisartan and not necessarily evident for drugs like losartan. But through numerous mechanisms, telmisartan seems to decrease smooth muscle reactivity over and above its effects on RAS. There are also studies on tumours suggesting that it alters blood flow within the lesions and reduces hypoxia, which I thought was interesting and could sort of fit into the changes in the hematocrit. And then also well known are the effects that telmisartan has through stimulation of the PPAR gamma receptor, which is of interest in terms of treating diabetes or diabetic nephropathy in people and things like that, because this changes insulin sensitivity, and I'm not sure how that would necessarily fit in, but it does sort of build in the picture that potentially telmisartan has more effects than just those on the renin-angiotensin aldosterone system. And sort of fitting in with that, if you like, in the drug trials that were done for treatment with telmisartan in cats with hypertension, one of the things that's quite notable with them is that you have an immediate reduction in blood pressure, but then when you follow those cats up over time, the blood pressure continues to decline for really quite a long period of time, sort of several months. It's still going down, and that's not really something that we appreciate with treatment with amlodipine, say. And arguably, would we see that just through effects on the renin-angiotensin aldosterone system? I guess you could say if you've got vascular remodeling and that effect is being reversed, maybe you would, but maybe there are other mechanisms at play as well. And then I guess the final couple of slides I had, which is what would you do to improve the study, or what additional studies need to be done? And I think it's kind of lazy to say, well, study size should be bigger. I mean, study sizes should always be bigger, and you look at the human studies and you've got like X many thousands and things, and wouldn't it be nice? But I imagine that getting the 40 dogs through the trial was a pretty monumental Herculean task. And actually, when I look at the data, and their follow-up time points were within 2 days of the target, which is actually incredibly difficult to achieve. And already they showed a statistical preference for one drug over the other. So I don't think actually just doing the same study with a bigger sample size would actually get us that much further forward. But I think having found what they have in this study, it would be nice to sort of look at specific groups of patients. So should we look at patients with overt glomerular disease, how, define that how you will, whether it was biopsy confirmed or just on the basis of a UPC over X amount or whatever, versus tubular interstitial, or patients with protein losing nephropathy. But again, what's your definition of that? Does the albumin have to have dropped to a certain level or something like that, versus other groups of patients? I think it would be nice to do that. I think showing a survival benefit is always nice, but those studies tend to be disappointing and they're hard to do. And then I think it would be really nice, and I hope they've collected samples and have them, and maybe this is in the pipeline, but if there were samples from the dogs in both arms of the study that could be used for measurement of the various angiotensins, the aldosterone and plasma renin activity, or the various surrogates of renin activity that can be done with mass spectrometry, I think that would be really interesting to look at and to see if there is any evidence of escape going on. And then my very last point is my personal headache, or the headache of anybody that practices in the UK, which is the prescribing cascade. And I know you probably tell me that you have a cascade too in America, and maybe things have changed, but certainly when I was a resident, I never noticed that anybody paid any heed to the prescribing cascade. In terms of we really are not allowed, when we've got a veterinary licensed drug, to use a human product instead. It's the sort of thing they make very clear that you'll be, if it's well documented, that it's, I don't know if you'd get struck off for it, but it's really not something that is done. And so the problem that I have is I read this paper and I'm like, yeah, I want to give my patients telmisartan, but if I've got a 30-kilo Labrador and let's say I want to treat it with 2 mg per kg of telmisartan, then if I use the cat product, which under the cascade I'd have to, we're talking about £12 a day or $16.50. Even though if I use the human product, and this is my online shopping, this isn't even using the RVC's very expensive pharmacy, this is online, then it would be just over $1 a day to treat them. But I'm obligated to go with the Symmintra because it's licensed in the cat, which is a bit of a problem. So, I mean, I hope maybe Boehringer is planning to license it for treatment in the dog. And I don't know if anybody knows if they are or not. But that was basically all I have in terms of slides.
That was great, Hattie. I wanted to just share a little bit of information. We have Dr. Lourenco, who is the first author on the paper, in the audience, and she provided an answer. You were asking about those non-azotemic, those stage 1 patients who were proteinuric, and she had stated that those were identified on just typically screening or wellness blood work by referring veterinarians, and they were referred to UGA for evaluation once they were found to be proteinuric. So to answer your question,
she must have better referring vets than I do. I don't know that enough of them measure proteinuria or UPC for me to have recruited that many, but that's great. Thank you, Bianca.
And I think a number of clinics are probably doing this more often. I mean, we're pretty lucky. We get UPCs done on our urinalyses as standard whenever we do them as part of our in-house urinalysis package. So I have to specifically not request a UPC if I don't want it. So that's really exciting that more clinics are hopefully being able to do the same. And then there was a little bit of discussion on are people still using pooled samples versus submitting single samples for the evaluation of UPCs, and a little bit of discussion. Jessica had mentioned that she had typically do a pooled sample of 3 for submission, grabbing a mil from each, and that's usually what we do in patients. I definitely will admit to doing single samples as well too. If they bring me a sample from home, we'll submit that single sample, and I'll be happy with that. So I try to encourage people personally to get several samples to bring in to try to eliminate some of that daily variability, but I certainly have submitted the single samples as well too.
Yeah, and in this paper they claim at least for the follow-up time points, it was a pool of three samples, and we try and get owners to do that as well.
And I think it was Jessica who asked the question, which leads right into I was creating a poll to kind of follow up with this. What's the drug that you are using as your first line anti-proteinuric drug? Just to get an idea of what people are doing, to get an idea of what.
So, and are you asking what have you done up until like maybe until this paper came out, or that you're going to do from now on?
Let's say prior to rounds, if you were to get a proteinuric patient this morning or 2 hours ago, depending where you are throughout the world, what would have been your first line drug if you found that they were proteinuric? We'll give it just maybe another minute and then we'll close to see what people have voted for. All right, I think we have a good number of answers, so I'll just go ahead and we'll close it. And I don't know if the poll shows up. Oh yeah, here we go. So looks like the majority were using telmisartan as their first line drug.
Yes, I mean, I think some of the before this paper was published, I mean, some of it had been presented in terms of abstracts and things like that, I guess. So that probably was weighing into people's choices.
Right.
Do you think?
Let me see. I think I have another one. Sorry, it's a little okay. And then for those people that are using ACE inhibitors, what's the starting dose of enalapril or benazepril that you might give for a non-azotemic patient? And I did this as mg per kg per day, recognizing that some people might prescribe it as Q24, some people might prescribe it as Q12, but just wanted to get an idea of the dose that people might use as they're starting an ACE inhibitor. I feel like most people are starting telmisartan for the management of proteinuria at that 1 mg per kg per day, so I figured it might be more interesting for our ACE inhibitor. So I'll give it just another couple seconds and I'll close this poll. Okay, and looks like most people are doing between about 1/4 and 1/2 mg per kg per day as a starting dose. Personally, in a non-azotemic patient, I would be higher. I usually use 0.5 mg per kg twice a day. I would have been with the 46% of folks.
Yeah, that's where I was as well. But mainly, maybe because I'm grumpy and I can't use telmisartan, or only if the owners are very rich.
I do feel bad for you. It's pretty reasonable here in the United States to be able to even just have them use it as compared to an ACE inhibitor.
You know, you're looking at $100 a week.
It's crazy. All right, interesting. And then I did have one other because they did talk about the dual therapy, and I just wanted to see how frequently people were prescribing. So think of this as if you can guesstimate what percentage of your current proteinuric patients that you have, how frequently are you doing prescribed an ACE inhibitor and an ARB? Have you never done it? Are you almost always doing it, or does it fall somewhere kind of in between? give this a couple more seconds. Close this. Okay. And it looks like there's a third of us who never have done dual RAS blockade, and then the largest chunk have been less than a quarter of our patients. That would be personally where I would fall, less than 25%. I do it. I often find that when we, and so coming from someone who starts telmisartan first, when I reach my max dose, which is usually about 3 mg per kg per day, at that point, if they're still proteinuric, but I've seen a good response, if I have room with their serum potassium, I will add in an ACE inhibitor. But as Julie Byron said, you can see some significant hyperkalemia. That's the biggest risk that has been shown in people with dual therapy. And I do believe that we see that as well too, that we can have a greater frequency of hyperkalemia. So I find that I'm often limited by the serum potassium concentration on how frequently I might be able to do dual therapy.
JD, I wanted to add a comment to Larry Adams. I have had the unfortunate experience of having a few more dogs than was noted in this study have a bigger drop in serum creatinine, and I think perhaps it's because looking at a lot more dogs with stage 2 CKD than was in this study. But I've had a fair number that, with even rounding down from the using the 20 milligram tablet, below a mg per kg starting dose of telmisartan, that their creatinines have jumped substantially. So I just worry about that a little bit more, having been burned a few more times than I would like.
And I would agree with you there, Larry. We've seen a handful of patients who've had an AKI after starting the telmisartan, and not necessarily in the first few days, where certainly I think they could develop some GI signs, but more like a week, 2 weeks, 3 weeks or so out. And I think part of it could be the owners were giving the medication while the patient was having some GI symptoms. They were becoming volume depleted and they were continuing therapy. And that's probably a failure on our end to better educate them on when to take a holiday from the drugs. But most of the patients have had good recoveries, but some have needed to be on fluids for 3 or 4 days to get themselves sorted out. And I don't think I've seen that with nearly the same frequency as when I've been starting or seeing patients see that after an ACE inhibitor. So I do think you have to be a little bit more careful. I don't know if others have seen similar things with that.
Looks like in the chat, Ohio State and Tufts have seen the same thing that you and I have seen, JD.
Yeah. And then Alicia Vincent brought up the idea of using patiromer for a potassium binder for those patients that need dual therapy. I can say personally, I've started using it because, and so for people who aren't familiar, patiromer is a potassium exchange medication. It exchanges potassium for sodium across the GI tract wall, really across through the capillaries. So it's a way to manage hyperkalemia. It works pretty quickly in people. Within just about 4 hours, you get, I think, about a point off of their potassium in general. We started using it for some of our hyperkalemic patients that are on dialysis. I haven't used it for patients personally that are hyperkalemic due to RAS blockade. I know certainly that's an indication of why they use it in people. I've just been a little nervous because I want to get a better handle on the frequency of GI signs we might see with it to potentially cause some pre-renal reduction in GFR, which then might cause your ACE inhibitor and or ARB or combo therapy to be a nice big second hit to the kidney. So I haven't yet. I don't know if any others are using patiromer or in this scenario or for other indications. Julie Byron said that she used it once and the dog stopped eating.
Dr. Labado was also asking in terms of the ACE inhibitor dosing, whether we'd tended to use different doses according to whether you were using enalapril or benazepril. And I think it's probably more dependent on the dog's clinical condition and whether it's azotemic or not, how cautious or bold I am, rather than which drug I'm using.
Yeah, I would agree. I'm similar. I would probably have my starting dose be the same. If I was using enalapril, I might consider not increasing the dose earlier in patients that were azotemic compared to benazepril because of its greater hepatic metabolism. You can probably get away with keeping the dose the same for a higher magnitude of azotemia before you're starting to have the drug accumulate. But I would start either of them at a 0.5 mg per kg, and if they're non-azotemic, I would treat them essentially the same. I would try to increase both of them. My personal max dose is 1 mg per kg twice a day for an ACE inhibitor, and I would do that with either if the patient was non-azotemic. All right, I'm just trying to see if there are any other thoughts. I do want to certainly thank you, Hattie, for the presentation. That was wonderful. I also want to thank certainly the UGA group for doing the study that was long needed, and it was a very intricate and meticulously designed study, and it's just wonderful to see very high confidence in their data and be able to apply it. So thanks to Dr. Lourenco and her colleagues for doing it. It's terrific. And overall, I thought it was a great paper and wonderful discussion. So really look forward to our next Journal Club meeting. I believe our next one, we don't have anyone who's signed up in 2 weeks. So if you're eager to it, we have an availability in 2 weeks' time. Otherwise, at the current moment, our next session is scheduled for the 14th of May, where Dr. Courtney Wright will be discussing some recent articles that evaluate dissolution therapy for feline screw-like uroliths, which should be great. So I'll go ahead and stop the recording.